So our two presenters this morning will be setting up the panelists here. So if anyone has questions that you'd like to ask. And there are some microphones on both sides of the aisles. We are recording this, so please use the microphones. And can you identify yourself?
Sure. Vivica Craig from Virginia Tech. Thanks, Dr. Johnson, and also Dr. Maddens for your presentations. My question is actually for Dr. Johnson. Since you've got experience with octogenarians, and maybe this will come up later in the day, but what can we learn in terms of a package of indicators of healthy aging based on the blue zones, people who do live to their 90s and into 100 and beyond from those hot pockets around the world in Japan and Sardinia and other places. So, because it kind of relates to the WHO definition you gave in the beginning, which we really need to have a more holistic way of thinking of physical, mental, nutritional well-being.
How many people read? No, yeah. How many people have read about the blue zone diets? Anybody? Few. Okay. It's really interesting. It's usually people have been identified in relatively smaller communities, not always, but many, and they do look at, the researchers looked at a holistic group. I mean, as a gerontologist, it doesn't really surprise me. If you're going to make it in a relatively small community, you do need to have family support, community support. You need to be eating something. If you're in an isolated area, you're more likely going to rely on local foods and things like that. So I think it's really interesting. And yeah, I would agree, it does reinforce the holistic outlook we need to have.
Good morning. My question is for Dr. Johnson. You talk about the importance of research in relation to protein and sodium. What about the role of sugar?
Excuse me, could you just have the microphone tipped down?
Yes, sir. What about the role of sugar, added sugar? Because I am always wondering whether anybody is studying the impact of sugar on the health of telomeres and in relation to inflammation, and of course, Alzheimer's, diabetes, and other multiple chronic condition and obesity.
Right.
Thank you.
Well, generally, our added sugars are not going to function that much differently than our natural, quote-unquote, natural sugars in terms of any disease outcome. I may need to refer that back to the audience regarding inflammation and things like that. But our broadest thinking right now is that overconsumption of energy really in any form is going to lead to problems. I don't really know what to say beyond that unless someone else wants to talk more about specific indices of inflammation.
It is an established fact that the sugar play a very significant role in the development of both metabolic and respiratory acidosis, which is foundation of all diseases. I mean, there is a lot of literature out there. And added sugar in particular, I think that is a very important area of nutrition research when we compare it in relation to protein or sodium.
Yeah.
Because when you really think about it, even in terms of absorption of nutrient like D3, like B12, which is very important in terms of development of Alzheimer's, sugar plays a very significant role.
Well, but again, we just need to be very mindful that an excess consumption of energy in any form, including natural or added sugar, can lead to metabolic consequences.
So Johanna, before you question, could I just have that previous speaker, questioner, identify herself, please? Give your name.
I'm Dr. Simin Wang. I'm an epidemiologist, and I work for Maxwell Stem LLC, which is an international company located in United Kingdom. Thank you.
Thanks. Okay. Johanna?
A sort of stupid question.
This is Johanna Dwyer.
My name is Johanna. The stupid question part is identification enough. I can't remember if assisted living facilities would be grouped, how would they be grouped in the national surveys? And do we need more information on what's going on there? The reason I say this is I had dinner on Sunday with a group of people who are over 80, in a very fancy assisted living place in Boston, and including a Nobel laureate. And here at this table, people were having all sorts of problems eating because several of them had Parkinson's disease, they couldn't see the plate and so forth. So I'm interested in what's going on in these very expensive facilities in terms of this.
It's an interesting question from an operational point of view. I believe in the standard definitions, they are not institutions, so they don't fall into the institutional population. So if you were doing, a household-based survey, they would probably fall into that sample. My fear has always been that the interviewer shows up at these places and goes, looks like a nursing home to me, and out, and then the nursing home, when we do the nursing home surveys, they show up and go, oh no, this is a household setting, and so they kind of get lost. When I first started, there were clear distinctions in kinds of places. There were homes, there were nursing homes, and you really could tell the difference, and now we have this continuum. And so there's been a lot of work trying to define the aspects of living arrangements and living places in order to do sampling frames. Most of the data that we've collected on assisted living and residential care has been from the long-term care perspective and not so much focusing on the household surveys, but I think we're moving towards a much more kind of integrated way of collecting information. It's much harder to do things like residential care, assisted living. They tend to be state regulated, so the definitions change. A lot of them are state-based. It's much harder to do in terms of trying to figure out what's consistently across. You have to do it in terms of the services offered. But I would certainly agree with you. We'd certainly need more about that. It's a growing area. I was surprised that it's smaller than the nursing home, in the data we're showing, because everybody I know is just talking about assisted living, residential care. So it seems like a much bigger deal, but I think that's a function of my social framework. But yeah, moving forward, it's that plus the amount of care that's being provided in the home, and that transition becomes really important.
Another thing about that group, just to build on that, it's housing with community services. It could be anything from a HUD facility for low income to maybe that glitzy place your friends are talking about, where it's private pay, you just keep paying, and then because it's often state regulated, it's going to vary on what are the requirements for nutrition services, whether they have a dietitian. I have not looked at the state regs lately, but the last time I looked was quite some time ago. There was one line, follow the dietary guidelines for American and the National Academy of Science, period. Okay, so I'm sure states have really moved much beyond that, but it's still going to require, a dietitian that understands the unique needs of aging.
Similar to other kinds of services, you can have good physicians and bad, good hospitals, bad. So the requirements and the definitions tend to be, it has to be a certain number of beds, you have to provide certain services. How you provide them, how well you provide them, that is something you have to do the research on and figure out. But it is it's a big area. It will be a growing area.
Sharon?
Hi, I'm Sharon Donovan, University of Illinois, and I have 3 questions and comments. One, Marianne, the study you talked about in Europe with the 3,200 subjects, are they collecting any diet information in that study?
I did not see that they are, but I can look into that.
Okay.
Yeah.
So the second comment is you didn't mention gut microbiome, and there's a very nice study out of Ireland where they followed elderly people living in home, living in kind of going to day centers and long-term care. And what they found is people moved into long-term care, likely due to diet and cohabitating, their microbiota became very similar, and it became much less diverse. And then they were actually able to make nice correlations between markers of frailty and some of the biological markers that you mentioned. So I think definitely looking at the microbiome, and there's some work now going in the older ages and 100 and over even. And the last one is the impact of exercise. And so Art Kramer, who was at the University of Illinois, just recently moved to Northeastern. He's done some really nice NIH-funded work looking at exercise and cognition in the elderly and showing how critical it is to maintaining cognitive function, and it also would help things like strength and balance. So, I think we need to make sure that exercise is featured, and just want to put in a plug for the microbiome.
Yes, all excellent comments, Sharon, thank you. And especially for the physical capability domain, well, all of the domains, for example, in the last slide, are very highly impacted by physical activity, absolutely.
Are there any more comments, questions? No? David?
David Goldman, USDA FSIS, Food Forum member. I'm not sure it's a question, but more maybe a challenge for all of us. In your description of the various studies looking at biomarkers, we have a myriad to look at. I mean, it's almost pick your favorite or two. What I wonder is I think we collectively done a nice job of describing the various biomarkers and their attributes and their associations with various conditions. I wonder if the next evolution of all this work is to decide when an intervention is appropriate, how to evaluate those interventions, and whether, using nutrition as the example, is nutritional intervention and therapy transitioning from the traditional sit across from somebody and tell them what they should and shouldn't eat to something more than that. And I just wondered, if there's something there you might want to comment on.
We have a considerable amount of data to translate into action and how to support people. Also, we're having a growing recognition that just telling people what they're supposed to be eating, that's not working all that great. And especially, I find that older people are very motivated. I'll just use the example of my father. Once he had a heart attack in his early 60s, he was on it. He got rid of all trans fats in his house long before the FDA did. And he just really got highly motivated. So there's often not a problem with motivation. However, as people age, they're going to lose some of their abilities to do what they want, to go to the store and get the food they want. I was talking with Linda. I don't know where she went. Problems with chewing. Maybe the food's not been adapted right. So I'm just bringing up more things we need to think about. But we do, to your point, we do need to become action-oriented in what is it we want to work on, priorities, what we want to work on to improve the food and nutrition situation for older people.
A question for Dr. Maddens and Johanna Dwyer. Your office does such a wonderful job with so many different surveys with such limited resources. I wondered if more resources became available, what you would think would be the best way to use those resources to develop more information that we need to design better programs for aging population.
Well, in kind of listening to some of your comments and other inputs, what you find is you're trying to looking at multiple indicators that will have an effect. But there is not, I think we're gone past, if we could just do this one thing, everyone would live longer and healthier and we all be in a good place. There's lots going on, they interact. And in order to tease that out on a national level, you really need bigger samples. And that is a function of money. So if you really want to look at the oldest old population, you can't just have the sample that we'd normally get if we just took a random sample. You have to design the survey so that you're getting more diversity in that population across a variety of things. And the measurement for us probably isn't as big a deal. We can do we do thousands of tests. But after a while, you run out of people to look at the variability on. So that was one. We have always liked to do longitudinal studies. As you can see, that was one of the things I like to do. I think that gives you a very different perspective than doing the multiple cross-sections, which are absolutely key. You have to be able to maintain tracking within the population. There's lots wrong, but if we didn't have the data, people are living longer, disease rates are going down, functioning is improving. I didn't have time to show some of the comparisons of the current 55 population to the 55 population 20 years ago, and what are they going to, as we age, we're probably aging healthier already. So you need some kind of longitudinal study. And then I think the point you brought up more, the looking at the provider side has never been as sexy as looking at the people side. It's much harder to get funding for things like a nursing home survey or an assisted care survey, which we used to do years ago and had to stop doing. We now do go to providers to get information. We've started to do residential care surveys, but we can't do them very often. And if there's a gap, I think, in terms of how do we, if we can't prevent a decline, which we may be able to do a better job, but if we can't, how do you provide the accommodation so that that decline doesn't have impacts on, for want of a better term, quality of life? And that has to come more, to some extent, from the service side, which we don't do as good a job. So it wouldn't cost a lot. We could do. I'll give you the bill later. We're being recorded.
Okay, are there any other questions or comments? Yep.
Thank you. I also think that it is not only nutrition alone when it comes to healthy aging. We need to pay very significant attention and focus on chronic stress and cortisol, because that also affects the quality of nutrition and what people they eat. That is one point. The other point is when it comes to our aging population, I think diffusing the information regarding raw eating as compared highly prepared food and packaged food, because I'm always thinking about the level of acrylamide in prepared food as compared to raw food, which is much healthier for our, and in terms of absorption of nutrient. So those are the two impacts that I think we need to do more research, and of course there's a lot of information available there with regard to chronic stress, cortisol, raw eating as compared to prepared food, and the level of acrylamide, and not to forget endocrine disruptor in the medication, which is being prescribed for our older population, namely hormone-loaded medication. Thank you.
And we want to be very careful about raw food and you know, a raw banana, good, a washed raw apple, good. But as we were talking about, as some people get older, they're going to lose their ability to chew or decline. And part of the modifications that we do to keep our food safe and accessible for people any age with a disability is certain kinds of processing. So we just need to make sure that we use all the food technology options we have available for a safe, nutritious, and accessible food supply for everyone.
Okay. Well, great. I'd just like to thank our speakers again this morning. And I think they'll be here a little bit longer, so that if there are more questions that you'd like to ask them, they'll be around. We are now scheduled right on time for a break, and we will ask that everyone please be back here ready to start at 10:30, because we do have a full day. Thank you.